Right, welcome to the virtual class. In this class, we are going to look at female reproductive cycles. So we'll be focusing largely on what we call ovarian cycles and the endometrial cycles. And in the process, we'll also talk about the hormonal basis of those cycles. Perhaps before we do that, just as a matter of introduction, you know that pregnancy is an obvious thing telling us that a woman is reproductively mature. But apart from pregnancy, menstrual bleeding is the other obvious manifestation of reproductive function of a female. Menstruation usually begins at the age of puberty and continues throughout the reproductive years of a woman. The first menstruation is termed menarche. And the age at menarche varies depending on different populations. There are some parameters, however, which have been associated with the onset of puberty or the menarche itself. Those parameters include the increasing body fat, which then affects the percentage between body fat and lean tissue. And we are going to say that in a different way shortly. Throughout the reproductive years of a woman, there'll be those events taking place. Now, the reproductive years of a woman end at a time called menopause. We define menopause as the cessation of menstrual flow for 1 year. And usually this one occurs between around the age of 45 to 49 years, around there. It could come early, maybe 40, but in most cases, 45 to 49 years. As long as menstrual flow has stopped for more than 1 year, around that time, we call that menopause. Now, during the reproductive years, there'll be some monthly, and I'm using the term monthly here. In quotes, we are going to qualify that shortly. There's some monthly changes which take place. Those changes involve the hypothalamus, pituitary gland, the ovaries, the uterus, fallopian tube, vagina, and even the breasts of a woman. They occur in a monthly basis. There's some monthly changes. However, for the sake of this lecture, we are going to focus on changes which take place in two key parts. The changes which take place in the ovary, we call those on the ovarian phases, and the changes which take place in the uterus. You can call them uterine phases or endometrial phases. So what is our learning outcome in this particular lecture? Maybe first we'll need to understand the gross anatomy of the uterus and also the histological layers of the uterine wall, because that information is going to be key. After that, we are going to look at the proposed mechanism that has been used to explain the onset of female puberty. Then we look at the hormonal axis that control the female reproductive cycle. We call that hypophyseal ovarian hormonal axis. We are going to see that hormonal axis. We are going to see how the length of the cycle varies. And we're also going to see the normal length of the cycle. Then now we'll focus on specific things. One will be the changes which take place in the ovary during the cycle. While we are there, we'll also extrapolate and look at the changes which take place in the endometrium. And while we're doing that, we'll look at the hormonal basis of them. So the hormonal basis of the ovarian changes and the hormonal basis of the endometrial changes. And we'll then look at the scientific basis of the safe days, or so what you people call the safe days. You may call it fertility awareness-based method of contraception. We're going to see that one, but maybe we can also extrapolate that one and talk about how can a couple maximize on conception. Lastly, we'll talk about the basis of gender selection. If this couple want female baby girl, what can they do, or what options can they intervene? If they want a baby boy, can they intervene a particular way? So this lecture is going to help us understand those ones. Quickly, let's go to the first agenda, which is basically to review the gross anatomy of the uterus and the layers of the uterine wall. So this is how the uterus looks like. Grossly, the uterus is described to have 5 gross parts. This part of the uterus is the fundus of the uterus. It coincides with that part. This part of the uterus is called the body of the uterus, and it coincides with that one. This down part of the uterus is called the cervix, and it coincides with that part of the uterus. Maybe you're familiar with those 3 already, but there are 2 others that I want to add. The junction between the cervix and the body of the uterus, this part here, that narrow part, is what we call the isthmus of the uterus. Isthmus of the uterus. Then this point here, where the fallopian tube attaches to the uterus, is what we call the corners of the uterus. C-O-R-N-U-S, corners of the uterus. So this is the right corners, and that's the left corners of the uterus. The term corners means horn. So right and left uterine horns. That is the general anatomy of the uterus. Maybe you can use that time also to review the parts of the fallopian tube. Remember the fimbria, infundibulum, ampulla, the isthmus of the fallopian tube, and usually there's a part that traverses the uterine wall, which we call the intramural segment of the fallopian tube. Okay, now we can look at the histological layers of the uterine wall. So this image shows us the cross-section of the uterus histologically. The outermost layer of the uterus is called perimetrium. It's a thin layer. Deep to that, we have a layer called myometrium. Myometrium is a layer that contains the smooth muscles of the uterus. Within the myometrial layer, there's some blood vessels. The layer of blood vessels within the myometrium is termed stratum vascularis, the vascular layer of the myometrium, stratum vascularis. The blood vessels run within that layer of the myometrium. Anyway, all in all, the whole of that is myometrium. So you realize that blood vessels run within the myometrium. And that is why when a woman delivers, this myometrium need to contract so that these blood vessels collapse to stop bleeding after delivery. The innermost layer of the uterus is the endometrium. This is the endometrium. Endometrium has 2 zones. There's a zone next to the myometrium. We call that the basal zone or basal layer. You can call it stratum basalis, the basal layer. And then there's that layer that is next to the lumen. We call the functional layer or the stratum functionalis. 2 things I want to say here. When menstruation takes place, usually it is the functional layer that is shed off. The basal layer remains intact. That's one thing I wanted to say. The other thing I want to say is that if pregnancy is going to be established, when the conceptus is implanting, it will implant up to somewhere there. It will go through the functional layer, but it will not go through the basal layer. So the conceptus reaches somewhere there. So those are the layers of the endometrium. And also, of course, the layers of the uterine wall in general. Now let's talk about the proposed mechanism that explain the onset of female puberty. Maybe you need to understand what puberty is first. Puberty is a process through which a child's body matures into an adult that is capable of sexual reproduction. So that whole process, what we call puberty. How is it initiated? It is initiated when a hormone called leptin, which comes from adipose tissue. Remember, adipose tissue is fat tissue. So fat tissue produces leptin hormone. As the levels of leptin hormone increase, which means that a baby is growing, and so the proportion of fat to lean tissue is increasing, and so the levels of leptin increase. That leptin that is rising is the one that promotes the secretion of another thing in the hypothalamus. That other thing is called kisspeptin. You can call it metastine. So leptin acts on the hypothalamus to promote the secretion of kisspeptin, which is also called metastine. In response, kisspeptin stimulates the very same hypothalamus, so that hypothalamus can begin secreting GnRH, which stands for gonadotropin releasing hormone. The hallmark of puberty is characterized by the beginning of production of GnRH. So GnRH production marks the hallmark of the initiation of puberty. What does GnRH do? GnRH hormone, GnRH, gonadotropin releasing hormone, acts on the pituitary gland. Remember, it's from the hypothalamus. It acts on the pituitary gland. And the role of GnRH on the pituitary is to enhance the release of two hormones: follicle stimulating hormone, as well as luteinizing hormone. Those are the gonadotropic hormones. That is why GnRH is called gonadotropin releasing hormone. So if GnRH stimulates the pituitary gland to produce gonadotropic hormones, the gonadotropic hormones in turn enhance the secretion of gonadohormones. These are hormones which come from the gonads. And because we're talking about female puberty here, we are talking about ovarian hormones, estrogen and progesterone. You realize that now there are many hormonal changes which are taking place. GnRH started to be released, then now it released FSH and LH, in turn releasing estrogen and progesterone. Those hormonal changes will trigger ovulation and the onset of puberty. And how will we know that puberty has started? The first menstrual flow. So the first menstrual flow marks the onset of puberty. But of course, there'll be some hormonal changes which have already taken place prior to that one, except that we couldn't see them. So perhaps menarche is the most obvious manifestation, and maybe that's why we use it, because clinically now somebody is able to pinpoint the age at which, or the month at which, or the date at which menstruation first came. There are other things that some people may use, like when the breast starts to pop up, we call that telake. But you can't tell, like, was it yesterday, today, or tomorrow? You can't tell when it starts to pop. So that is more of a graded thing. But menarche is very characteristic, and that's why we use it. When a female starts puberty, and so the cycles begin, the earlier cycles may not even be associated with ovulation. The cycles may be anovulatory, which means that she may not ovulate during those cycles. Fine, there is menstruation, but the cycles are not associated with the releasing of the oocyte. Also, when puberty begins and around those earlier times, the cycle length varies a lot, from maybe 10 days to even 60 days or more. So what I mean is that a woman may see flow today, and then 10 days later, she sees another flow. That means in a month, she may see her flow twice, or even thrice in a single month. And that could worry her, but understand that when puberty is beginning, especially the earlier phases, the cycle length will vary. Sometimes a woman may see her flow, and then 2 months later, she's not seen anything again. Maybe I should be using the term a girl, not a woman, but I hope you understand what I mean. So those earlier days, the cycle length vary a lot. This image captures what I've told you about the mechanism of initiation of puberty. So what we have is that eventually we'll have release of gonadotropin releasing hormone. The age at which puberty will be initiated may vary. So as I told you, it may vary depending on populations. Sometimes may come at the age of 8 or 9 years, 10 years, 11 years. It can vary. But all in all, when GnRH begin to be released from the hypothalamus, it will go to the pituitary gland. And that will trigger the release of luteinizing hormone and follicle stimulating hormone. That happens in both male and female. So in female, the two hormones will then act on the ovary to have some changes. We are going to talk about those changes shortly. In males, the two hormones also act on the testes to cause some changes. But we are focusing on female in this lecture. So now let's look at the hormonal axis so that we understand that flowchart in a better way. We've mentioned that hypothalamus produces a hormone called gonadotropin releasing hormone. That gonadotropin releasing hormone acts on the anterior pituitary gland. The other name given to anterior pituitary gland is adenohypophysis. So GnRH acts on the adenohypophysis. As the name suggests, it promotes the release of gonadotropic hormones. So yes, because of the effect of GnRH, gonadotropic hormones will be released. There are two gonadotropic hormones, follicle stimulating hormone and luteinizing hormone. We call them gonadotropic hormones because they are tropic to the gonads. In this case, the gonad is the ovary. They stimulate the ovary. What are the specific effects of this hormone? Follicle stimulating hormone, as the name suggests, causes follicular maturation. Having talked about oogenesis, having learned about oogenesis, you may know what that really entails. as the oocyte matures towards ovulation. Apart from that, follicle stimulating hormone also stimulates the secretion of estrogen hormone. Luteinizing hormone, on the other hand, causes ovulation, and it also causes production of progesterone hormone. So this is the hormonal axis that control the female reproductive cycles. We call it hypothalamo-hypophyseal ovarian hormonal axis. And this happens repeatedly throughout the cycles of a woman, as long as it's during the reproductive age of a woman. That is what happens every month. Having said so, let's now talk about the normal cycle length and explain also how it varies. So the cycle length varies considerably among women. Maybe you need to understand, first of all, what is cycle length. Cycle length is the duration taken between the beginning of one menstrual flow and the beginning of the next menstrual flow. So that is what you call the cycle length. The beginning of one menstrual flow to the beginning of the next menstrual flow. You count the number of days, that is cycle length. I told you that at the beginning, it may vary a lot from 10 days to 60 days or even more. But as this girl child grows and matures towards adulthood, remember now she's an adolescent. As she grows to mature towards adulthood, some degree of regularity is established. That degree of regularity would range from maybe 21 days to 45 days. Remember, not yet an adult, but we are achieving some maturity, which means that the cycles are now not too short, neither are they too long. For most adult females, which means they're already mature, they take about 28 days. Well, majority will fall within this category of 27 to 30 days that will apply to most women. From physiological point of view, 21 to 35 days is considered normal. And generally, 90% of women will be in the category of 23, or let me say 24 to 35 days. 90% of women will be in that category. Few females will be having 21, 22 days. And those ones particularly may not be ovulating. If the cycle length is too short, the duration it gives for the follicles to mature may not be adequate. And so those ones who have 21-day cycle, 22-day cycle may not be ovulating in particular. I'll tell you why that could be so when you look at the follicular phase of the ovary and look at the days that it requires. Now, as a woman grows towards within adulthood towards menopause, the cycle lengths begin to lengthen again. Maybe about 2 to 8 years before menopause, the cycle length begin to lengthen again. So instead of, if let's say they were taking 28 days or 30 days, now they take 32, then maybe 35, and even go beyond that one, 40 days, 45, until there is cessation of menstrual flow for 1 year, which we now term menopause. The length of the cycle can vary or can be altered by a number of things. We are told that if a woman is so emotionally stressed, the periods can disappear totally. And then you start thinking that you're pregnant. Maybe that even adds more anxiety and it even makes it disappear even more. Maybe some sickness can also make the cycle to be altered. If the woman is malnourished, if the woman is obese, there's some seasonal variations like weather changes can also make the cycle length to vary. Maybe it was regular, but something has happened. Maybe you're having 24-day cycle, something happens, now it's 26. Or you've been having 28-day cycle, something happens, whatever happens, then now it's 30 or 24. Right, so those are that is cycle length and how it varies. I want to take note that the average is 28 days and physiologically normal is 21 to 35. Although if you have 21, 22, maybe you are not ovulating. From 24, maybe you're ovulating. So I want us to now look at the ovarian phases. And we are going to state the hormonal basis of each phase. Before we look at the ovarian phases, I want you to be familiar with the ovarian follicles. From your lecture on oogenesis, maybe you're already familiar with it, but let's just repeat it here. As the oocyte develops within the ovary, the number of cells that support the oocyte increase. The squamous flat cells are known as follicular cells. The cuboidal cells are generally termed granulosa cells because they usually contain some granules within them. Even if you call them follicular cells, okay, but a unique type of follicular cells that we call granular cells, granulosa cells. You are aware again that as the oocyte develops, there is a glycoprotein covering that surrounds the oocyte. We call that glycoprotein covering the zona pellucida. This zona pellucida is between the oocyte and the supporting cells. Now, the whole complex that contain the supporting cells, zona pellucida, and the oocyte is what you are calling the ovarian follicle. And usually the follicle will continue to grow, become bigger and bigger, and we'll be talking about them shortly. So what are ovarian cycles? Ovarian cycles begin at the age of puberty and end at menopause. And it involves rhythmic changes which occur in the ovary. The rhythmic changes which occur in the ovary are caused by the gonadotropic hormones. We talked about that cycle, that axis. They are caused by the gonadotropic hormones. So follicle stimulating hormone is responsible. Luteinizing hormone is also responsible for the ovarian cycles. What do these hormones do? These two hormones cause some three things to happen in the ovary. They cause the ovarian follicles to develop. And that period when the ovarian follicles are developing is termed the follicular phase of the ovary. The hormones also cause ovulation. And we call that the ovulatory phase of the ovary. they also cause formation of the corpus luteum. And that time when we have the corpus luteum is termed the luteal phase of the ovary. So I want us to look at these phases one by one. Let's start with the follicular phase of the ovary. The follicular phase of the ovary begins on the first day of each cycle. However, we don't usually use this to determine the first phase of the cycle because you don't know. As a woman, you can't tell. But there's something characteristic that happens when the menstrual flow begins. The first day when menstrual flow begins is usually the first day of the cycle. That time when menstrual flow begins, the first day of the cycle, is the same time that follicular phase also begin in the ovary. Remember, menstruation is taking place in the uterus, but this is happening in the ovary. They begin around the same time. That's why I'm saying that follicular phase begin on the first day of the cycle. Follicular phase is driven largely by the follicle stimulating hormone. So the follicle stimulating hormone will be causing the follicular development. And remember that follicle stimulating hormone was also causing estrogen production. It is for that reason that the follicular phase of the ovary is termed the estrogen phase. So this image shows you the follicular phase of the ovary. The main thing that happens during the follicular phase is the recruitment and growth of ovarian follicles. So the ovarian follicles become recruited and they grow to maturity. When you talk of recruitment and growth of the ovarian follicles, what does that really entail? It entails the growth and differentiation of the primary oocyte, which means that the primary oocyte continue its meiotic division after being arrested at prophase 1. It now continue the first meiotic division. Apart from that, the supporting cells that surround the primary oocyte also increase in number. The zona pellucida will also form around this time. And the cells of the ovary around the follicle, which we call thicker folliculi, will also develop. So that is what growth of the ovarian follicle entail, those 4 things. Let's see that in this particular slide of the ovary. We are going to use this to understand the ovarian follicles and how they grow. But we're also going to use it to understand the different types of ovarian follicles that we have. Consider this to be the ovary. The ovary has 2 parts. The central part of the ovary, this one, is called the ovarian medulla. The ovarian medulla contains connective tissue and blood vessels. But this outer zone of the ovary is called the ovarian cortex. The ovarian cortex contains ovarian follicles at different stages of maturation. So this is the ovarian cortex, which contains the follicles, which are at different stages of maturation. In this image, we can see the ovarian cortex and the ovarian medulla. In particular, I want you to take note of this layer here. There's a layer that covers the ovary. We call it the ovarian capsule. It's a connective tissue layer that covers the ovary. We call the ovarian capsule. Deep to that is the cortex, and then the medulla. The ovarian cortex contains ovarian follicles at different stages of maturation, but there's something else that it also contains. It contains the stromal cells of the ovary. So the stromal cells of the ovary refer to the cells of the ovary that surround the follicles. The objective of this slide is to take us through the different types of ovarian follicles. So let's do that. The most primitive form of ovarian follicles are called primordial follicles. These are the primordial follicles. They're usually subcapsular. Maybe a higher magnification will show us that better. This is the ovarian capsule, and deep to that, we see the ovarian follicles here. We call them the primordial follicles. What do we notice about the primordial follicles? One, they're small. They exist in groups. They are subcapsular. And look at the type of cells that surround them. They're surrounded by squamous cells, one layer of flat cells. So I'll repeat their characteristic. They're subcapsular. They exist in groups. They are smaller, and they're surrounded by simple squamous epithelial layer. The follicular cells is squamous cells. When these ones are recruited, now they become the primordial follicles. And in the lecture on oogenesis, remember about 15 to 20 are recruited every month. So when they're recruited, they become the primary follicles. How do you notice a primary follicle? This image will show us primary follicles. A primary follicle is surrounded by cuboidal cells instead of squamous cells. So that's a primary follicle. That's another primary follicle. That's another one. That's another one. That's another one. And that's another one. They're surrounded by cuboidal cells instead of squamous cells. Something else also we note, and especially compared with the primordial follicles, that the primary follicles are away from the capsule. We can also note that they are not really in groups, and they're larger compared to primordial follicles. There are two types of primary follicles. There are these primary follicles that have only one layer of cuboidal cells. We call them unilaminar primary follicles. As the primary follicle grows, it will have multiple layers of the supporting cells. Maybe this other image is better. So we see more than one layer of supporting cells. We call this one the multilaminar primary follicle. Perhaps at this time, the supporting cells already have granules. And so we call them the granulosa cells. As the primary follicle matures, it develops a cavity inside it. They're usually small cavities that coalesce to form one large cavity, which we call the follicular antrum. When the follicle has an antrum, you can call it antral follicle or secondary follicle. There would be multiple types of secondary follicles, depending on the size of the follicular antrum. Others maybe just be forming like that or that one. And the others may be fully formed. The antifollicles are the ones we can call secondary follicles. As secondary follicles mature, the size of the follicular antrum increases. A few, if not one, will mature in a successful month. The one that matures will be very unique. We will call the mature follicle. And how do we know that it's the mature follicle? The mature follicle will have some characteristic feature. It will be very near the capsule of the ovary. And actually some protrusion will be there. That protruding part of the mature follicle is called the stigma. The follicle with the stigma is the mature follicle, which is also known as the Graafian follicle. So those are the different types of ovarian follicles. So during the follicular phase of development, or rather follicular phase of the ovary, the follicle matures and go through those stages we talked about. There's some hormonal concepts that I want you to understand about the follicular phase. In the early follicular phase here, as the number of follicular cells increase, the levels of estrogen increase as well. As the levels of estrogen increase, that will provide a negative feedback to the ovary. Sorry, a negative feedback to the pituitary gland as well as hypothalamus. When you talk of negative feedback of hormones, it means that the end product inhibits further secretion of the stimulus. So in this case, because of negative feedback mechanism, the rising estrogen levels suppress further secretion of follicle stimulating hormone. Remember, that is early follicular phase. We have a negative feedback mechanism. So there is reduced production of follicle stimulating hormone from the pituitary because of rising levels of estrogen. This image captures that maybe in a better way. We talked of the hormonal axis, hypothalamus to pituitary, then to ovary. Ovary produces estrogen and progesterone. So I'm saying that estrogen offers a negative feedback. It inhibits the pituitary as well as the hypothalamus so that we don't have further production of GnRH, or rather, let me say, the production of GnRH and FSH go down in the presence of rising levels of in this particular month to continue the development. The smaller follicles are usually FSH dependent. And so when you decline the levels of FSH, when you deprive them of FSH, those follicles undergo atresia. So that explains to you the hormonal basis of follicular atresia. They become atretic follicles, and that's the other type of follicle that are present in the ovary, in addition to the ones we talked about, atretic follicles. The follicles which are larger usually are FSH independent. They don't rely so much on FSH. And so FSH deprivation does not affect them. Those follicles, which are larger, will therefore continue to grow and mature and perhaps now become the Graafian follicle. In most cases, that will be only one follicle, but there are cases where multiple follicles can actually mature. So just to review the parts of an antifollicle, because this becomes important when you're going to understand the next phase of the ovary. That part labeled A is the oocyte. If this oocyte is just before ovulation, then that will be secondary oocyte, which means it has completed the first meiotic division and even began the second meiotic division, then perhaps arrested at metaphase 2. That part labeled B is a zona pellucida. The part labeled C is the basement membrane, in the understanding that these follicular cells are epithelial cells, so that's the basement membrane of the epithelium. The part labeled D refers to the population of granulosa cells immediately surrounding the zona pellucida. We call them the corona radiata. The part labeled 5 refers to the population of follicular cells or granulosa cells that suspend the oocyte. We call them the cumulus euphorus. That is the follicular antrum, remember? And these ones here are the granulosa cells that are external to the antrum. We call that stratum granulosum. So this is the stratum granulosum. The cells of the ovary, the stromal cells of the ovary immediately surrounding the follicle, we have the theca folliculi. There are two zones of the theca folliculi. The inner zone of theca folliculi is highly cellular. We call that the theca interna, and the outer one, fibrous with some spindle-shaped cells, we call that the theca externa. During ovulation, this is the part that is ovulated. Okay, those are the parts of the antifollicle. So once the follicle matures, what next? It goes to the ovulatory phase. The ovulatory phase, we can explain it this way. And I want you to understand this hormonal graph. So the follicular phase was characterized by rising levels of estrogen. So because the levels of estrogen were rising, it caused some negative feedback mechanism on FSH, and you can see the decline there on FSH. Estrogen usually has an effect on the pituitary gland as well. What it does is that it increases the number of GnRH receptors on the pituitary gland. So if you have high levels of estrogen, that causes a rise in the number of GnRH receptors on the pituitary gland. So what is the effect of that? When the levels of estrogen are so high, the GnRH receptors have increased in their number. The implication is that even very little levels of FSH will have significant output on the pituitary gland. Sorry, let me say that again. If you have several GnRH receptors on the pituitary gland, it means that even very tiny levels of GnRH will have significant output on the pituitary gland in terms of production of FSH. So what I'm saying here is that the pituitary gland is very sensitive at this point to even very small levels of GnRH. Because of that, there'll be a surge of the follicle stimulating hormone as well as the luteinizing hormone because of the increasing number of GnRH receptors. What do you notice? We see that rising levels of estrogen have caused a rise in the levels of luteinizing hormone and follicle stimulating hormone. We call that a positive feedback mechanism. Now, not a negative feedback mechanism that we noted in the early follicular phase. Now we are seeing a positive feedback mechanism where a rise in the levels of estrogen cause a rise in the levels of the gonadotropic hormones instead of a decline. That positive feedback mechanism explains the mechanisms around ovulation. So in this image, the rising levels of estrogen cause a positive feedback mechanism on the system, causing further release of gonadotropic hormones instead of the negative feedback of the early follicular phase. During the late follicular phase, we have a positive feedback mechanism. Because of that positive feedback mechanism, we'll have a luteinizing hormone surge. The luteinizing hormone surge causes a rise in the levels of progesterone. Remember, luteinizing hormone causes progesterone secretion. The rise in progesterone levels, which is here now, that rise in progesterone levels, or starting from there, that rise in progesterone levels is important because the one that triggers the molecular mechanisms that lead to follicular rupture and expulsion. Some of the things that happen during the follicular rupture and expulsion is this. There's a lot of secretion of prostaglandins. At that time, the follicle becomes red. Hyperemia means red, basically. And there's some enzymes which are also released because of the presence of progesterone. Those enzymes break down collagen, so they're collagenase enzymes. Basically, they break down proteins. And because they break down proteins, they will weaken the wall of the follicle. They will also weaken the wall of the ovary at the position of the stigma. Those proteinases. Other than that, because of the rising levels of prostaglandin, we are going to have a lot of fluid filling the follicle. And that means that the follicular antrum is going to swell significantly. The swelling mechanism is also facilitated by the weakening of the wall, so more fluid enters. With increasing amount of fluid in the follicular antrum, coupled with degeneration of the stigma, the follicle will rupture. And when the follicle ruptures, the oocyte, zona pellucida, and coronal radiata are extruded from the ovary. What remains in the ovary will now form the corpus luteum. Now, the things that remain will be the stratum granulosum, as well as the thicker folliculi. And those ones form the corpus luteum. So this image captures that well. This is the oocyte. It is extruded here. And what remains is the corpus luteum. That brings us to the luteal phase of the ovary. The luteal phase of the ovary is characterized by the presence of the corpus luteum. Remember the granulosa, the stratum granulosum will become the granulosa lutein cells, and the thicker folliculi will become the thicker lutein cells. These ones produce the ovarian hormones, but now progesterone more than estrogen. It is for that reason that we call the luteal phase the progesterone phase. Usually the corpus luteum will involute some 11 to 14 days later if there's no pregnancy. However, if there is pregnancy, the corpus luteum lasts for about 2 to 3 months. I want you to understand something about the ovarian phases as we finish them. We can actually say, yes, I've talked about 3 phases, but we can actually say that there are 2 major phases of the ovary. The first half, follicular phase, when the follicle is developing. The second half, the luteal phase, when the corpus luteum is present. The luteal phase is relatively fixed at 14 days, 2 weeks. The follicular phase is variable. That follicular phase that is variable usually can take 7 days or even 21 days. It is because of the variability of the follicular phase that now the length of the cycle varies. And so if a woman has a 35-day cycle, the ovulation does not necessarily take place at the mid-cycle. And I want to capture that very well. If a woman has a 34-day cycle, don't make an assumption that now they ovulate on day 17. Most likely that woman will be ovulating on day 20 of the cycle. Because of what I've told you, that the luteal phase is relatively fixed at 14 days. So after ovulation, 14 days later, menstruation. So if this woman has a 34-day cycle, they ovulate on day 20, so that 14 days later, that makes 34 days. If a woman has a 24-day cycle, most likely she ovulates on day 10 and not 12. That means, again, if she ovulates on day 10, 14 days later, the end of the cycle, menstruation takes place. You have to understand that concept if you are going to advise a woman accurately on how to calculate their fertility window. If you don't understand that concept, you will not be able to accurately advise a woman or advise yourself on your fertility window. Remember, luteal phase is relatively fixed at 14 days, 2 weeks. The follicular phase is variable. Why did we say that if a cycle length is 21 days, then most likely it is an ovulatory? The reason I said so is because it is noted that the follicular phase requires at least 10 days for the follicle to mature. At least 10 days for the follicle to mature. So if a woman is having a 21-day cycle, and we are saying that the luteal phase is about 14 days, that makes the follicular phase to be 7. Not adequate for maturation of the follicle. Great. That is the ovarian phases. We now want to talk about the endometrial phases, and we'll also state the hormonal basis of each phase. Maybe you need to understand that when you talk of uterine cycles, it refers to the changes which occur in the uterus during the reproductive years of a woman. These changes are caused by estrogen and progesterone hormone, which come from the ovary. Understand, remember the ovarian phases were caused by gonadotropic hormones, which come from the pituitary. The changes of the uterus are caused by hormones which come from the ovary, estrogen and progesterone. The changes largely occur within the inner layer of the uterus, what we call the endometrium, and they involve some 4 stages: the menstrual phase, proliferative phase, secretory phase, and ischemic phase of the endometrium. Let's talk about them. We start with the menstrual phase. The concept I built is that the first phase of the ovary is called the follicular phase, characterized by production of estrogen, so we call it the estrogen phase. The second phase of the ovary is characterized by the presence of the corpus luteum, and so we call the luteal phase. During that period, there is production of progesterone, and so we call it the progesterone phase. But I told you that the corpus luteum lasts for only 14 days if there is no implantation. If the corpus luteum disappears after 14 days, it means that now we will not be having progesterone and estrogen from the ovary, at least not in their normal levels. When the hormonal production goes down, it causes significant change on the endometrium. Because of the involution of the corpus luteum, estrogen and progesterone production ceases from the ovary. And that ovarian hormonal deficiency is the one that causes ischemic changes in the endometrium that leads to disintegration of the endometrium. And that is what explains the menstrual phase. So menstruation occurs because of ovarian hormone deficiency. Usually, the flow will mark the beginning of a new cycle. So this is the day 1 of the cycle. The flow lasts for about 5 days, plus minus 2. I understand most women will take 4 to 5 days. But even if they take 3 is normal, 7 is normal. The amount of blood that flows is about 80 ml. It can range between 20 to 80 ml of blood. But what comes out may not just have blood only. What comes out as menstrual flow contain, in addition to blood, there's also mucus from the endometrium and desquamated endometrial tissue. That is what will make it maybe now more, but the blood itself is about 20 to 80 ml. That blood usually does not clot under normal circumstances because it has anticoagulants within it. And perhaps that's a good one, that's a bright move. You can imagine if it was able to clot. So it will clot inside the uterus itself. You want it to come out. That's the menstrual phase. After the menstrual phase, the endometrium enters the proliferative phase. This is a period of epithelial repair and regeneration. This is caused by a rise in the levels of estrogen. Remember, in the follicular phase, the levels of estrogen are rising. Because of rising levels of estrogen, we have endometrial proliferation. For that reason, we call the proliferative phase of the endometrium the estrogen phase. It is characterized by a rise in the levels of estrogen. So this is the rising levels of estrogen during the follicular phase of the ovary, and that causes endometrial proliferation. As the levels of estrogen rise, usually the cervical mucus will be thin initially, but as the levels of estrogen rise, the cervical mucus becomes more abundant. So the volume of cervical mucus increases. Apart from the increasing levels of cervical mucus, the mucus also becomes thin, elastic. Now that is very important because this is what happens towards the time of ovulation. The cervical mucus becomes it becomes more elastic, which means more stretchy. And that usually happens towards the time of ovulation, so that a woman is actually able to know that she's ovulating by just looking at the amount of cervical mucus that is there. After the proliferative phase, the endometrium enters the secretory phase. The secretory phase is marked by branching and curling of endometrial glands as well as blood vessels in the endometrium. This largely affects the functional layer of the endometrium. The glands within the endometrium secrete glycogen-rich material, and that is why we call it the secretory phase. Now, what is the hormonal basis of the secretory phase? The secretory phase is largely because of an effect of progesterone. Remember, when ovulation takes place, we have the corpus luteum in the ovary producing progesterone. The rising levels of progesterone cause the endometrium now to have these changes, which characterize the secretory phase. So we are here now. It is during this phase of the ovary that we have the secretory phase of the endometrium. Around this time, when the progesterone levels are high, the cervical mucus becomes reduced and also thick and stickier. The aim here is to block sperms from migrating. You can imagine sperms swimming through porridge. They can't go far. It is based on this concept that you have the e-pills, the emergency contraceptive pills, which uses progesterone only. A rise in the levels of progesterone makes the cervical mucus thick, and so sperms cannot swim through. Okay, if fertilization takes place in a particular cycle, it means that there'll be implantation going on during the secretory phase. It is during the secretory phase that implantation occurs. If implantation takes place, then there'll be a hormone that will be produced from the implantation site. We call that hormone human chorionic gonadotropin. That hormone maintains the corpus luteum so that the corpus luteum will not disappear in that particular month. If it doesn't disappear, then what happens? It will continue to produce progesterone and estrogen. Therefore, we can say that the secretory phase will continue. Menstruation will not occur. We call that the pregnancy phase of the endometrium, that prolonged secretory phase in the presence of pregnancy. So usually the corpus luteum pregnancy will last for about 2 to 3 months, after which the placenta takes over the role of hormonal production. So it doesn't mean that when the corpus luteum disappears, now we have decline in hormone. No, at this point, now the placenta has taken over the role of hormone production. That's why we no longer need the corpus luteum, but we still need the hormones anyway during pregnancy. However, if fertilization does not occur, there'll be no human chorionic gonadotropin, and that means that the corpus luteum will involute. Therefore, the levels of estrogen and progesterone will fall. And for that reason, the endometrium will enter the ischemic phase. That ischemic phase is what happened just before menstruation takes place. So it is characterized by a decline in the levels of estrogen and progesterone. During that time, the glands stop to produce their secretions. The interstitial fluid is also lost at that time, and so the endometrium shrinks markedly, becomes smaller. The arteries become constricted. The arteries in the endometrium become constricted. The veins within the endometrium now move at a slower rate. That's what we call stasis. And it means that the endometrium will be lacking in oxygen. And so it will be an ischemic state of the endometrium. At that time, there are some blood vessels that will also rupture. And because of that rupturing of blood vessels, there'll be blood flow. So the blood will flow out, and when it comes out, then we call that the menstrual phase of the endometrium. Great, so those are the endometrial phases. This image summarizes for you that storyline. From the pituitary, we had FSH and luteinizing hormone. FSH caused the ovary to undergo follicular phase. And so the follicles increase in size until when they become big and ovulation take place. After ovulation, you have the corpus luteum. In the presence of luteinizing hormone, the corpus luteum produces progesterone. However, that lasts for 14 days when it involutes. When the corpus luteum involutes, it becomes what we call the corpus albicans. In the follicular phase, we have rising levels of estrogen, while in the luteal phase, we have rising levels of progesterone predominantly. And so the first phase is called the estrogen phase, and the second phase is called the progesterone phase. The estrogen hormone has an effect on the endometrium, where it causes the endometrium to undergo proliferation, as you can see here. After ovulation, you have progesterone, and so progesterone has an effect on the endometrium, where it causes the endometrial glands to develop and the blood vessels to proliferate. We call that the secretory phase. If the corpus luteum involutes, we have a decline in the levels of ovarian hormones, and that causes ischemia and subsequently menstruation. Right, so that is the endometrial phases. We now want to explain the scientific basis of the safe days, so to speak. We call that fertility awareness-based method of contraception. So what's a safe day? A safe day refers to the duration or the days of the cycle when a woman is unlikely to conceive. The days of the cycle when a woman is unlikely to conceive. Or put in another way, the days of the cycle that pregnancy is unlikely. Now, this is based on physiological changes that take place during the cycle. For a woman to know their fertility window, and so the safe days, they must be able to know some of these things, the cycle length. They should be able to pick the physical manifestation of ovulation. For example, some women may have some pain during ovulation. or we've said that the cervical mucus increases in amount during ovulation. So some of those physical manifestations become important. But also important is that for you to understand the safe days, you need to understand the lifespan of the gametes. Remember that the oocyte is viable for 24 to 48 hours. The oocyte is viable for 24 to 48 hours. But in most cases, 24 hours. That's the oocyte viability. Lifespan of the sperm, as well as the lifespan of the oocyte. What is the lifespan of the sperm? The lifespan of the sperm is about 2 to 3 days, sometimes may stretch up to 5 days. The lifespan of the oocyte is 24 hours. It may stretch up to 48 hours. So usually, if a woman has sex 5 days to her ovulation, there's small chance of being pregnant. But if she has sex within 2 days to ovulation, she has a very big chance of getting pregnant. Understand it's not 100%, but that's a big chance. If she has sex 24 hours after her ovulation, there's still some chance of getting pregnant, although the chance has declined. If she has sex beyond 48 hours after ovulation, there is 0 chance of being pregnant. And that graph shows us that information. So a few days to ovulation, there's a chance, and the chance increases and becomes maximal around within 2 days to ovulation. And after ovulation, the chance is very minimal. So the safe days are which ones? The days when the oocyte is unlikely to meet with the sperm. Those are the safe days. And so if the day is not safe, we call it the fertility window. The fertility window refers to the days when the oocyte is available. And so if the woman has sex, it's chance of the sperm and the ovum shaking hands. For you to understand that, you'll have to know when the woman is ovulating. Remember what I told you about cycle lengths and the time of ovulation. So you have to understand that. For example, if a woman has a 24-day cycle, you know that they ovulate on day 10 and not day 12 or 14. If they ovulate on day 10, look at the lifespan of the sperm. 3 to 4 days later, they'll still be alive. So you have to calculate using that concept. If a woman has a 28-day cycle, they ovulate on day 14. It means if they have sex on day 11, 3 to 4 days later, the sperm will still be alive. There'll be a possibility of conception. After ovulation, it relies on the lifespan of the oocyte, 24 hours later. All right, the last thing I want to talk about is the basis of gender selection. Is it possible for a couple to decide that they want a baby boy or a baby girl? And the answer is yes, but remember, it's just a chance. And now this is based on these two concepts. The sperm that makes male, the Y sperm, is very jumpy, swims very fast, very active, but it doesn't survive the acidic environment of this vagina or the female tract for long. So yes, it swims faster, but dies early. Maybe that's the one that will die on day 2. On the other hand, the egg sperm, the one that will give us baby girl, is very slow. Okay, not very slow, but it's slower than the Y sperm, but is able to withstand the acidic environment of the female tract and so lives longer. Maybe these are the ones that will stay for 3, 4, 5 days. So if you want a baby girl, you may want to prioritize. You may want to give the egg sperm an upper hand. And how do you give the egg sperm an upper hand? Having sex a few days to ovulation, so that by the time ovulation is taking place, you only have majority of the egg sperm and very few of the Y sperms. So in that case, the egg sperm will have an upper hand. If you have sex on the day of ovulation or when ovulation has already taken place, the sperm that will have an upper hand is the Y sperm, the sperm that swims faster. And so the likelihood would be a baby boy. But if you have sex a few days, maybe 2, 3 days before ovulation, that will give an upper hand to the egg sperm. So that is how gender selection can be influenced. Remember, it's a chance, because we say that there are many sperms which are released during ejaculation. So we are saying that yes, the Y sperm swim faster, but we're not saying that within 2 hours after sex, that the only sperms which are on the front line are the Y sperms and not X sperm at all. We're just saying that majority of the frontline sperms will be Y sperms, but there'll be a few X sperms which are still in the front line. After some 3 days, the sperms which are in the female tract will be majority X sperms, but there'll be a few Y sperms. So gender selection is not an absolute thing, it's a chance thing. Great. I think now we are done with that. And so I will stop there. Thank you very much.